Well, Justin, good to have you here, man. The next round of persistent pain kicks off next week. So just want to kind of dive a little bit deeper into, man, what do you think are some of the key takeaways for this course? I mean, someone who's going to jump into it, like, what are some of the highlights and things that they can expect to get and actually change their behaviors when they walk away from that 8-week online course?
Yeah, well, I think there's probably three, and it starts with a really strong neurophysiologic understanding of the actual experience of pain. I think part of the problem with our pain epidemic and our culture around pain and the way we treat it is sort of a fundamental misunderstanding of the experience itself. So we're going to dive really deep into the science from normal nociception all the way up through maladaptive neuroplastic pain.
Go ahead.
Okay, I think the second thing is taking that information and then translating it into how it changes the way that we engage patients from a connecting with the patient standpoint to actually having tools to evaluate a patient from a neurophysiologic, psychologically informed standpoint, from a top-down approach, looking at things like pain pressure threshold testing, 2-point discrimination, and kind of fear avoidant behaviors, and teasing in all of the factors from sleep and stress and all of the holistic type things that really are involved in patients' persistent pain states.
I mean, dude, I love that because we talk at ICE all the time about how your physical exam, right, should be catered to your N=1. I mean, the data that you collect should be relevant for what your primary hypotheses are that are driving the patient's condition. Yet so often we see people who have someone in their room that they're pretty sure is centrally dominant. I mean, the maladaptive beliefs are there, the catastrophizing is there, and yet we evaluate them in looking at hip flexor length, in looking at all these things that are basic musculoskeletal impairments. Not that those can't be relevant, but certainly you would think looking at the exam of a centrally dominant patient should look somewhat different than from someone who's more nociceptive, peripheral musculoskeletal driven.
Absolutely. Yeah, you can't have a neurophysiologic approach that's a top-down approach that's guided from a biomechanical evaluation. There's got to be other pieces. And I think the deeper understanding of the physiology opens the window for us to understand that we can look at things like pain pressure thresholds and 2-point discriminations and left-right discrimination and really key into some of those central neuroplastic changes. And also understanding things like patients' rumination state, their catastrophizing state, their fear avoidance state, and how we can not just use those as checkboxes on evaluation forms, but to really use those as treatment targets to move those metrics in a way that drives our patients forward.
And I mean, Justin, can you speak a bit to treatment? Because very similar to the exam, again, I think that we're still suffering from a profession of, I love what you say. I think you say, talking Mosley, but still practicing Descartes. We're talking about doing these things that are individualized for a centrally dominant patient, but our interventions don't reflect that. I mean, can you speak to some of the interventions that people are going to walk away from this course actually incorporating versus just giving lip service to?
Yeah, absolutely. I think, looking at a persistent pain patient, we have to think about them from the maladaptive beliefs and negative expectation standpoint. We know that those are the foundations that outcomes are built on. So we absolutely have to have our understanding on point well enough that we can educate patients in a way that that's neurophysiologic based, that decreases fear, that increases hope. So education is a big piece. But there's so much more to a persistent pain patient than just talking to patients about pain and then moving into the next thing. Once we understand that these neuroplastic changes happen in the cortex when we have pain for a long time, and in the cord and in the periphery, and we have evaluation techniques to get after some of those dysfunctions that we were just talking about. So now looking in using localization discrimination training, looking at laterality training, looking at graded motor imagery progressions that go from laterality where appropriate to actual motor imagery, all the way up through using mirror boxes and how to grade and progress mirror box therapy in the appropriate patients. And then looking at patients from a movement and a global standpoint where we can actually incorporate graded exposure in ways that we break down specific fearful movements and grade patients back into being able to go from, I haven't flexed my spine in 30 years, to being able to tie their shoes. Or looking at their I talk about global graded exposure, looking at their just general activity and strain levels and what they do during a day and figuring out where we can toe into where they're at. with respect to physical and psychological irritability, and then slowly building a program that builds them into an active, healthy lifestyle that's so focused on function and way less focused on pain.
Well, dude, I love it, man. Because I mean, I really look forward to a future where when we recognize some of these maladaptive characteristics, some of these sensitivities, that you see the physical exam incorporate a pair of calipers and actually look at normative data and look at, you know, is somebody willing to engage in certain movements? Are their fears on board? What is their ability to discriminate, touch, and feel? And then actually go into treatments that mirror those objective findings. I mean, I think, to be totally frank, we're a ways from that. But I think that this course is designed exactly to get someone going from talking the part to actually behaving this way with patients. And to me, that's just thrilling.
Yeah, absolutely. I think when I talk to clinicians, one of the things that I hear over and over again, especially when you get, you know, we've all seen them, the patient that walks in the door, everything hurts. When you touch them, they jump off the table. They're not sleeping. They're totally stressed. They have no level of physical activity. Every body part hurts. And when that patient walks in the door, you know, it's like, if you are going to examine every single region of pain from a mechanical standpoint, you know, that's a 12-day eval. And it's, I think where clinicians get frustrated is where do you start with those patients? And I think when you get the better understanding for neurophysiology, for how chronic widespread pain is an upstairs problem, not a downstairs problem, it really kind of funnels in the things that you can look at. Basically, it's the difference between looking at the body from a mechanical standpoint versus looking at and figuring out how to evaluate the nervous system and then applying treatments that make sense for that. And then you actually have objective measures from a neurologic standpoint that you can put in your paperwork, but more importantly than that you can show your patients actual change. When the patient walks in the door and you can't touch them and they jump off the table, and then you can show them that their pain pressure threshold went from 0 to 4.8 pounds in the last 2 sessions. Now Doris gets a little bit of hope that finally somebody's on the right track and moving needles in the right direction.
I love it, man. Building the appropriate bike. You know, it's due time. And this course has been so successful and so wonderful. I'm glad we're able to offer it a few times a year.